In this module, we're going to discuss women's health in general. We're going to talk about the reproductive system, menstrual cycle, and common health issues that women face throughout the lifespan. The major structures of the female reproductive system include 2 ovaries, 2 fallopian tubes, a uterus that includes an endometrium and cervix, and the vagina. The ovaries are 2 oval-shaped organs, one on each side of the uterus. The ovarian ligament and broad ligaments help keep the ovaries in place. Within the ovaries, there are several thousands of immature follicles, and these follicles are present at birth. Each follicle has the opportunity to become a mature ovum, otherwise known as an egg. And we'll get into that when we talk about the menstrual cycle. Maturation of an immature follicle takes place because of hormones, especially estrogen. Right along the side or above the ovaries are 2 fallopian tubes. The fallopian tubes, at the end of them, have finger-like projections that are called fimbriae. The purpose of the fallopian tubes is to take the mature ovum or egg and transport it through the tube into the uterus. Key to remember in the fallopian tubes is usually where fertilization takes place. So the fallopian tube, through peristaltic movement, wave-like movements, takes a fertilized egg or an unfertilized egg into the uterus. The uterus is shaped like an upside down pear. It's about the size of an average size fist. The upper portion of the uterus is called the fundus. The main purpose of the uterus is to house or accommodate the fertilized egg, have it ready for implantation. Once implantation has occurred, then it grows and expands for the developing fetus. Within the uterus is the endometrial lining. This lining thickens in preparation for implantation of that fertilized egg. The narrowing end of the uterus is what we call the cervix. The cervix is basically starts in the uterus, and its ending point is an opening to the vagina. The vagina is a muscular tube that extends from that cervix into the perineum, or the outer area of the vagina. The functions for the vagina is to receive sperm during sexual intercourse. It is the exit for menstrual flow if fertilization implantation hasn't taken place, and it is known as the birth canal during labor. Let's begin to discuss the menstrual cycle. In essence, there's 2 purposes of this cycle. One is the development of a mature egg, and the second part is the preparation for the housing of this mature and fertilized egg to be implanted into the uterus. The normal cycle that we use when we discuss the menstrual cycle is a 28-day cycle. For most women, their cycle varies and is not 28 days. It may be shorter or it may be longer. But for the purposes of learning and when we start to discuss hormonal contraception, the 28-day cycle is used. During a woman's lifetime, her menstrual cycle is repeated anywhere between 300 and 400 times. Bleeding, or menses, what we call it, normally lasts anywhere between 3 to 8 days, and the average blood loss during each one of those cycles averages around 30 to 80 milliliters. I'm not going to spend a whole lot of time talking about these various characteristics that lead up to the first menses, because you get that in pediatrics when you start talking about puberty. But what I do want you to know is that the menarche is what we call the first menses. So a young woman's first period is called a menarche. The menstrual cycle is a system of negative and positive feedback involving the hypothalamus, the anterior pituitary gland, the ovaries, and the endometrial lining of the uterus. This feedback system is influenced by 4 major hormones that are essential for the menstrual cycle and ovulation to occur. Follicle stimulating hormone, or FSH, luteinizing hormone, LH, progesterone, and estrogen are all key players in the menstrual cycle. Here I've included 2 videos that gives visual as well as verbal explanations of the menstrual cycle. The first video gives a great overview of the menstrual cycle and how all of the feedback systems and the hormones come into play to develop a mature follicle or egg, how ovulation occurs, and what happens after ovulation to the endometrial lining of the uterus, and how all of these things work in concert together. Then the next video breaks down the involvement of the hormones in the menstrual cycle, and it breaks it down into what the hormones do pre-ovulation and what those hormones, the responsibilities of those hormones after ovulation has occurred. It's essential that you understand the process, because when we start to talk about family planning, and we need to talk about when ovulation occurs, when a woman is fertile, when we talk about contraceptions, things like that. So if there's questions or concerns after reviewing the videos, after reading, and after this lecture, please feel free to contact me. Let's shift our focus now to menstrual irregularities. First, we'll discuss amenorrhea. Amenorrhea means no menses. It can be broken into 2 categories, primary and secondary. Primary amenorrhea, there is no menarche, nor are there any secondary sexual characteristics by the age of 14. Meaning that a young woman at age 14 has had no period, and she presents upon assessment having no breast buds or development of any pubic hair or hair in the armpits. Also, If the young woman is at age 16 and has had no menarche, the first period, regardless of her normal growth and development, that would be considered primary amenorrhea as well. 90% of these cases have no identifiable cause. Other times it can be related to hereditary, that they're late bloomers and that their menses is coming, or that there are some issues in the hypothalamus, pituitary area, which would alter those hormones that are released in those two areas. Follicle stimulating hormone, gonadotropin releasing hormone, which we know helps to trigger the menstrual cycle. Management usually consists of emotional support or hormone therapy if there is some hormonal imbalance identified. With secondary amenorrhea, there is no menses for at least 3 to 6 months after a woman has had regular cycles. So when you think about that, what comes to mind as the first differential diagnosis that we may have for a woman who reports no menses for 3 months after having normal cycles? Pregnancy, right? We have to rule out pregnancy. So secondary amenorrhea can be related to pregnancy, other endocrine issues, polycystic ovarian syndrome, which we'll talk about later. Stress can alter our cycles and delay the normal cycle. And so management would be finding, identifying the underlying issue and treating and caring for that. Continuing with our discussion of menstrual irregularities, we're going to discuss dysmenorrhea, or painful menstruation, painful periods. Dysmenorrhea is one of the most common gynecological problems that women present to their healthcare providers. As with amenorrhea, dysmenorrhea can be broken down into primary and secondary dysmenorrhea. And we'll discuss primary dysmenorrhea first. When you think about the menstrual cycle and the releasing of or the shedding of the endometrial lining, the uterine muscles contract in order for that shedding to take place. And prostaglandin is key for that contraction to occur. So prostaglandin is a myometrial, that's the muscles of the uterus, stimulant, and it's a vasoconstrictor. So it's causing that uterine muscle to contract in order for the lining to shed. So in primary dysmenorrhea, there is an overproduction of prostaglandin. And so these women have extremely painful menses that can affect their ADLs, their activity daily living, right? So it can cause a problem with work or school because of the pain. So primary dysmenorrhea is not caused by any type of pathology. It is simply that some women have an overproduction of this prostaglandin, which is a stimulant that causes painful cramping. So some key things to management or treatment of primary dysmenorrhea, we can use things like prostaglandin inhibitors, i.e. ibuprofen, or other type of analgesics, naproxen, things like that. Heat, Warm soaks in the tub. Exercise has been shown to help. Um, Oral contraceptives, and we'll get into that when we get into that module about hormonal contraceptions. And other things um, like acupuncture or yoga can also help. Unlike primary dysmenorrhea, secondary dysmenorrhea is caused by some type of pelvic pathology um, or anatomical dysfunction, such as things like endometriosis, pelvic inflammatory disease, which is PID, myomas, otherwise known as fibroids, that can cause painful menses for women. And we'll discuss these in some slides later on in this module. So the key to management for secondary dysmenorrhea is identifying and treating that underlying condition. So we would treat the endometriosis, we would treat the pelvic inflammatory disease in order to relieve the menstrual pain caused by these secondary pathologies. Here are some other common menstrual irregularities, and I'll just give you the definitions of them. So just be familiar with the definitions. Oligomenorrhea is infrequent menses or infrequent periods. They're spaced out, occurring greater than every 35 days. So these women have spaced out periods. Menorrhagia is a woman who has regular cycles. They occur on a regular 28, 30, 31, whatever her regular cycle is. However, she has excessive bleeding, and the bleeding occurs for longer days. So there's an excess in bleeding and an excess in the number of days she's bleeding. However, her cycle occurs on a normal calendar date. Menorrhagia is bleeding between periods. So a woman may be, let's just say she's on a 28-day cycle, or somewhere in between the first day of menses and the next one, she has some type of spotting or some irregular bleeding. This also can be this term can also be used when you think of a woman who has gone through menopause, and we'll talk about menopause later on. But a woman who's gone through menopause should never have any bleeding from the uterus again. Menomenorrhagia is excessive irregular bleeding. So not only is this bleeding occurring at the wrong time, i.e. in between her normal cycle, but now it's heavy and it's lasting for a long amount of time. And then lastly is hypomenorrhea, and this is less bleeding. So she's having her regular cycle. She's having a cycle every 28 days. She's having a bleed every 28 days. However, that bleeding is small or scant in comparison to what it normally is. And so that difference between hypomenorrhea and oligomenorrhea, hypo, normal cycle, small amount of bleeding. Oligomenorrhea is the cycles are spaced out. And so they may be regular in the amount of bleeding and how long the bleeding lasts, but they're spaced out. They're greater than 35 days. Also, a good rule of thumb when you get into all of these terms, and this isn't just in women's health or maternal child, but just something to note to help memorize or to help clue you into what a term means, is learning some prefix and suffixes that are attached to a lot of these medical terms. So, for example, if you have the suffix "ria," that means a flow or discharge. And if you have "raja," that's an abnormal flow or discharge. The prefix "oligo" means scant or few, and you'll hear that term again when we get into the prenatal period, when we start talking about amniotic fluid or problems with amniotic fluid. So oligo is scant or few, and hypo means less or few or beneath. So take those suffixes and prefixes, and you can apply those to other medical terms to help you with definitions. Premenstrual syndrome, or PMS as it's commonly known, is a combo of emotional and physical symptoms that around 30 to 80% of women present with during their within their menstrual cycle, and particularly during that luteal phase. It is a complex disorder that has been trivialized in the media and on TV, and it is just now coming into the forefront as a real condition that women experience, and so that the stigma associated with PMS is starting to decrease. So women can have symptoms ranging from lower abdominal and back pain to muscle pain. They may have diarrhea, constipation, bloating, changes in mood, headaches. There's a variety of symptoms that can be related to PMS. And these symptoms usually diminish or decrease after menstruation, after her period begins. And so we know that PMS can have a negative impact on a woman's life. And the best way to diagnose or to see if a woman has PMS is to have her keep a menstrual diary. And so you would have the woman start on the first day of her menses, which is when the cycle begins, and then to note on what days and what symptoms she's having issues, and then note when those symptoms resolve. And so if you see a pattern, usually over 3 cycles, that will help direct the provider in the direction of PMS. Women may experience a disorder that exceeds the normal bloating or physical symptoms associated with PMS, and may be presenting with PMDD, premenstrual dysphoric disorder, which is a medical diagnosis that is billable, and these women have severe mood-related symptoms. So in order for a woman to be diagnosed with PMDD as opposed to PMS, she would have to present with at least 5 affective, meaning mood-related symptoms, and physical symptoms that occur during that luteal phase, and again resolves during the follicular phase. So some of these affective symptoms would be feelings of sadness or anxiety, extreme moodiness, where she is a totally different person during this time period, and marked um, irritability or anger. The symptoms usually have a profound impact on work or other interpersonal relationships, and it's not due to any other disorder. So we've ruled out depression or any other psych or mental type of illnesses. And so, again, a woman would be encouraged to keep a menstrual log of the symptoms, when they occur, and when do they resolve. Please note that there is no single medication or lifestyle change that's um, needed or that can treat both PMS or PMDD. It would be a combination of lifestyle changes, and for some cases, especially with PMDD, the need for some type of pharmacological regimen as well. So things like we talked about, like exercise and diet changes, decreasing caffeine intake, decreasing salt intake, our lifestyle changes. And as far as meds go, things like oral contraceptives that have an impact on that luteal phase, and we'll get into that. And for women who have PMDD, which is strongly related to severe affective mood type of changes, SSRIs, or selective serotonin reuptake inhibitors like Prozac or Zoloft or Paxil may be beneficial for these women as well. I want to talk about a couple of other gynecological problems that affect women. We'll discuss endometriosis, polycystic ovarian syndrome, and uterine fibroids. First, endometriosis. So endometriosis is a condition where some of the endometrial tissue, that endometrial lining of the uterus, plants itself or is growing outside of the uterine wall. And this typically affects about 10% of all women. Some of the common places where endometrial tissue can be found is on the tubes, on the bladder, on the ovaries, anywhere. And what happens is that this endometrial tissue responds just as if it would if it was inside the uterus during the menstrual cycle. So during the follicular phase, it grows, and then in some instances during that luteal phase, because there's no implantation, that there is some bleeding. So women may notice that spotting when we talked about menorrhagia, spotting in between menses, that they may it may be related to endometriosis. The symptoms vary between women. What usually brings women in is pelvic pain, particularly around that luteal phase, dysmenorrhea. They may have dyspareunia, which is pain with intercourse, and issues with infertility. So when we talk about treatments for endometriosis, usually for women who are not trying to conceive, hormonal contraception can be recommended. And again, when we talk about oral contraceptions, you'll get a better sense of why. NSAIDs for pain, and even possibly surgery to try to remove that growth of the endometrial tissue that's outside of the uterus. Polycystic ovarian syndrome, or PCOS for short, is an endocrine disorder that affects a small percentage of women. The cause of PCOS is unknown. Usually, women present because of issues with infertility. Um, what a typical woman with PCOS would present with upon testing is that she'd have elevated levels of estrogen and testosterone and LH or luteinizing hormone, but she has a decreased follicle stimulating hormone, which we know is needed in order for a follicle to develop into a mature ovum. Up on an ultrasound, what we'd also see is that this woman has multiple cysts in the ovary, so we call those follicular cysts. Her menstrual cycle is usually irregular. She may have oligomenorrhea, where they're spaced out or absent menses, so secondary amenorrhea she may present with. She also could present with hirsutism, which is some hair growth, increased hair growth on her face or even on her chest, because again, she has these elevated testosterone levels. The woman may, obesity is a risk factor as well. So when we think about treatment of PCOS, things like diet and exercise, because these women are also at increased risk now for type 2 diabetes. She may be put on a low dose hormonal contraception for women who don't want to um, conceive, because these hormones decrease testosterone levels, things like that. If she is trying to conceive, she would be a strong candidate for fertility issues. And so when we think about endometriosis, polycystic ovarian syndrome, and even uterine fibroids, which I'll discuss next, we have to not only consider physical complications, but also the psychological effects that these disorders can have on a woman, especially when she is trying to conceive. And that can be said true with anything ranging from primary dysmenorrhea to PMS, PMDD. We always have to consider the psychosocial, psychological impacts that these disorders have on our clients and address those as well. Leiomyomas or uterine fibroids are more common than endometriosis or PCOS. And particularly African American women are more prone to uterine fibroids when we compare ourselves to our Caucasian counterparts. Uterine fibroids are benign tumors that are found within the uterine wall. Um, Sometimes they can be on the outer part of the uterine wall. They vary in size as well as their location. They can be as small as an acorn and large enough where a woman may look like she is pregnant. Women can have multiple uterine fibroids at once. And so if you imagine the structure of the uterus and you have large or any type of abnormal growth within the uterus, that can cause problems. And women will complain of pelvic pressure, or they may have menstrual issues, they may have heavy bleeds or irregular bleeding, painful menses as well. Physically, a woman may notice that she is not able to um, lose weight, or her stomach isn't flat, and these would be things that would bring a woman in to see her provider. Women can and have conceived and had successful pregnancies with uterine fibroids. Again, it is dependent on the size, the location, and the number of fibroids that are present inside of the uterine wall. Certainly, if a woman becomes pregnant with an uterine fibroid, she would be monitored closely, because the uterine fibroid, as well as that fetus, would now be competing for uterine space. Treatment for uterine fibroids range from laser surgery to what we call myomectomies, in which the actual benign tumor is removed from the area. For women who are having heavy irregular periods and who are no longer of childbearing age, or not wanting any more children, hysterectomy, in which the entire uterus is removed, is also an option. It's to be noted that with a myomectomy, again, that removal of just the uterine fibroid, that there is a possibility of that fibroid returning. And also, now that there has been a removal or some type of, if you will, damage to the uterus, that also can impact implantation if one is trying to conceive now or in the future. There's also a procedure out there called UAE, uterine artery embolization, in which you basically kill the artery, or you cut off the artery that is feeding the blood supply to that uterine fibroid. And so then that fibroid becomes necrosis, and then it dies off. And so there are multiple options depending on where the woman is in her reproductive life and the severity of the number and size of the uterine fibroids. Pelvic inflammatory disease, or PID, which it's more commonly known, is an infection of the upper genital tract. So fallopian tubes, uterus, ovaries can all be affected. And it's important to note that any type of infection to the upper genital tract, and particularly fallopian tubes, can have a significant impact on fertility. And so women with PID are at high risk for infertility issues, and also ectopic pregnancy, which is a pregnancy where a fertilized egg is implanted in the tube, in the fallopian tube, as opposed to in the uterine wall. So when we think about causative agents of pelvic inflammatory disease, chlamydia and gonorrhea are the most common causative agents, and in particularly untreated chlamydia and gonorrhea, in which the infection, the chlamydia, ascends. So it means it moves up from the vagina through the cervix into the uterus, into the fallopian tubes, and it continues to spread in that upper genital tract area. Women who are suspected of PID would come in and complaining of severe abdominal pain, may be related to the ovaries, and may be in the uterus. They would have pain with intercourse. Women would also present with some abnormal vaginal discharge that has a foul odor to it, and these women are more likely to be febrile, so there is an infection occurring. And so if you think about, if you're drawing labs, then WBCs, white blood cell counts, things like that would be elevated. And so in order to some diagnostic tools would be on a ultrasound or an MRI, there would be some fluid in the fallopian tubes. Okay, and again, this is the body's defense mechanism trying to fight off this untreated infection. So treatment, I'll talk about in the next couple of slides, but just note that, you know, a woman is at greater risk for ectopic after having PID because there is scarring in that fallopian tube. And so the transfer or that movement of the fertilized egg through the fallopian tube is halted because of scarring. And so women with PID are again at an increased risk for increased risk for an ectopic pregnancy. And so treatment of sexually transmitted infections, and particularly chlamydia and gonorrhea, are essential to decrease a woman's risk for developing PID. And when we talk about sexually transmitted infections in another module, I will reiterate that fact. For the most part, women are treated for PID on an outpatient basis. And so, as you can see on this slide, the treatment dosage for treatment, outpatient treatment for a woman with PID. She should be seen again in no later than between 48 and 72 hours. And if she is responding well or has responded well, then you can have her come back in about 4 to 6 weeks just to reevaluate. We want to, again, treat the underlying sexually transmitted infection. So if she's, you're also testing and treating for gonorrhea and chlamydia, and so you want to treat that as well. It's important to have her partner or partners treated, again, to reduce the risk of reinfection for the woman. And she may also use, over-the-counter pain meds for management of abdominal pain. There are instances where inpatient treatment for PID is optimal. For example, if a woman is pregnant, she should be treated on an inpatient basis. If you have a woman who may not follow through on the prescribed outpatient regimen, it's best to admit her for inpatient treatment. If there is a woman who did not respond in that 48-72 hours of the outpatient regimen, then she too should be treated on an inpatient basis. And as you see on the slide, the regimen for treatment on inpatient basis. Regardless if a woman is treated inpatient or outpatient, client education is extremely important. It's important to discuss with the woman risk factors that increases her risk of PID reoccurrence or sexually transmitted infection. occurrences, things like, multiple sex partners, um, uh, not using barrier methods, i.e. condoms, when engaging in sexual intercourse. So education is important, and we'll talk more about patient education in relation to sexually transmitted infections when we get to that module. Now we're going to talk about women's health screenings in general. It's important that at every encounter we have with female clients that we talk about health promotion, health prevention of certain diseases, especially things that women are at risk for. And so encouraging and discussing health promotion, health behavioral changes is key. So things like encouraging women to have regular health care. We always talk about diet, exercise, but we also need to talk about sexual health, talking about ways to protect oneself from pregnancy and sexually transmitted infections, discussing with women who are of childbearing age about family planning, talking about mutually monogamous relationships, and then getting specific with certain health promotions and preventions that are age appropriate. So talking about age appropriate screening, so things that we're going to talk about, breast screening, mammograms, Pap smears, things like that, all to reduce risk. Please use this link to access ACOG's, which is the American Congress of Obstetricians and Gynecologists website, regarding their recommendations for well woman screenings. It's divided into age categories, and so click on each age category links and become familiar with some of the standard screenings that are appropriate based on a woman's age, and it tells you how often one should get these screenings. For example, mammograms starting at age 40, then yearly. When we talk about colonoscopies, age 50s, again, take some time and become familiar with some of those basic screening tools. Again, because as nurses, we need to work for health promotion and health prevention, and not just when a patient presents with some type of issues. 1 in 8 U.S. women will develop breast cancer over the course of her life. Women in the U.S. have higher death rates from breast cancer than those of any other country besides lung cancer. Besides skin cancer, breast cancer is the most commonly diagnosed cancer among American women. So early detection is key, especially when we look at the trends that women are dying less often as a whole in the U.S. from breast cancer, and we believe that is contributed to early detection. And so I have two links here. One is a video. The first is a video from the National Breast Cancer Organization that describes self-breast exams, clinical breast exams, mammograms, biopsies, and ultrasounds. As healthcare providers, as nurses, we should strongly encourage our clients to perform self-breast exams monthly. Women should really do those at a time in the month where their breasts aren't sore or tender. Also, women should have annually clinical breast exams that's done by a nurse or a midwife or their gynecologist or primary care provider. On the next couple of slides, we'll talk about mammography and when one should get an early mammogram. The second link here is from breastcancer.org, and it gives a step-by-step with pictures of how to perform a self-breast exam. One things to clue in and to key in on is that women should examine underneath the arm, in the axillary, under the armpit, because there is breast tissue that goes into the axillary area, and that these using the pads of your fingers, the tips of your fingers, that there should be a constant circular or up and down motion, and that your fingers should not leave the skin, that you don't miss a spot. So please take a look at these two, one video and then the link to the steps of how to conduct a self-breast exam. According to the National Cancer Institute, women age 40 or older should have mammographies, mammogram screening every 1 to 2 years. It should be done earlier if the woman is high risk for breast cancer. If she's had a family history, a first generation relative, i.e. her mom, sister, who have had breast cancer, then the screening should be done earlier. And if she's been screened for 2 tests, BRCA1 or BRCA2, which are tests to screen for genes that are specific to breast cancer. I've posed a question here, and we can discuss this in the discussion question, that American Caucasian women have the highest incident rate of breast cancer. However, African American women are most likely to die from the disease. And so I want to have a conversation discussing why do we believe that this is true. We screen for cervical cancer through a procedure called a Pap Smear. And what we're doing is taking a sample of cells from the cervix, and we're screening for HPV, human papilloma virus. Now, this virus has over 30 different strands, but we know that there are some strands that are specific to cervical cancer. The guidelines for screening or conducting, or when a woman should have a Pap smear, have changed. So now a woman should have her first Pap at age 21, regardless if she's sexually active or not. Now keep in mind, a Pap smear is not the same as screening for sexually transmitted infections. So if a young woman, 18, or someone under age 21 is sexually active, she should be screened for sexually transmitted infections. But a Pap smear, which is specifically looking at abnormalities, HPV on the cervix. After age 21, she should have a Pap done every 2 to 3 years if the Paps are normal. If a woman has a trending history of normal Pap smears, meaning there's no abnormalities on the cervix, by age 30, she can move her screening to every 3 years. Again, if she is sexually active, she should still continue to be screened for sexually transmitted infections. At some point in a woman's life, usually around the age 50, 51, 52, she will she will stop menstruating. Therefore, she will no longer be capable of reproducing. And this is called menopause. Menopause is the cessation of menstruation for a full 12 months. So for 12 months straight, this woman has had no signs of bleeding at all. If she is, she has no menses for 4 months, and then month 5 she has a period, then she's not in menopause. It has to be a complete 12-month cessation of no menses. So we diagnose menopause after the fact. After a woman comes in and she says that I have not had any type of vaginal bleeding for 12 months. The time period leading up to this complete cessation of menses is what we call perimenopause. And this is that time where that we're most familiar with when women complain of hot flashes or other symptoms of irregular periods, mood changes, things like that. And these things are in relation to hormonal changes, because remember, estrogen and progesterone are key in our menstrual cycle. And so what we find is that during this perimenopause period, that there is a decreasing of estrogen in the woman's body. And so we'll talk about what impact that has on a postmenopausal, a woman who has gone through menopause, what impact that has on her. So perimenopause is this process of transition from regular cycles to menopause. Perimenopause can take up to 10 years. So a woman in her mid-40s can start to have these irregularities in her cycle, and she can start to have hot flashes, and this may last up until for 10 years. Women may also talk about sleep disturbances, vaginal dryness, and changes in their libido as well. Risks related to this decrease in estrogen production that causes menopause or a woman to be postmenopausal increases a woman's risk for osteoporosis, heart disease, because estrogen has a heart protective quality to it. Estrogen also has an impact on bone reabsorption, and so women are at risk for osteoporosis. So we need to counsel women who are postmenopausal on weight-bearing exercise, use of calcium supplements, counseling against smoking and heavy use of alcohol, which all can affect, have an impact on heart disease as well as bone reabsorption. We should talk to women about sexual health, because I talked about the lack of estrogen causes an increase in vaginal dryness, which can have an impact on sex for these women. And so when a woman, again, when she goes through the physical change of menopause, we have to talk about how that change impacts her, not just physically, but again, emotionally and psychologically. What does that mean for her and as well as her partner? One treatment modality that has been used often is hormone replacement therapy, or HRTs. And HRTs are used to manage the symptoms of perimenopause, the vasomotor symptoms such as the hot flashes, vaginal dryness. Um, it protects against bone density loss, and it's prepared in either an estrogen only um, source or a combination of estrogen and progesterone. And it's key to know that if a woman still has her uterus in place, that she should be giving an estrogen progesterone combination hormone replacement therapy. Estrogen alone would increase a woman's chance of uterine cancer. So if a woman still has her uterus, she has not had a hysterectomy, then she needs to be given a combination estrogen progesterone HRT, so the progesterone can protect the uterus. Um, HRTs can be given or prescribed orally, topically, or intravaginally. So, for example, if a woman is her only complaints is vaginal dryness, she can have um, uh, a intravaginal cream or gel prescription of HRTs. HRTs are to be used for the short term, um, recommended 1 to 3 years. There are certainly women who are not candidates for hormone replacement therapy, women who have known heart diseases, women who have had a history of or currently have some type of cancer, so a breast cancer, ovarian cancer, are not candidates. Women who are smokers would be discouraged again from using hormone replacement therapy, and alternative modalities would be discussed. Osteoporosis is a decrease in bone mass and an increase in bone fractures. Although all women are at risk once they reach postmenopause, but Caucasian and Asian women are at a higher increase of osteoporosis, even more if they are of small frame or short in stature. Um, the first sign that one can detect that one is trending towards osteoporosis is a decrease in height. Doing a bone density scan or DEXA scan by the provider would it's kind of like an X-ray of where you take a picture of the bones and see how the bone mass looks. Um, Things to help with prevention or treatment of osteoporosis is adequate calcium and vitamin D intake, um, doing weight bearing exercises, avoiding excessive alcohol, smoking can also help, and the use of medication biphosphates like furosemide can also help with osteoporosis. Here are 2 links to videos that discuss 2 eating disorders: bulimia nervosa and anorexia nervosa. Please pay close attention to the differences between the two, the reasons why one may engage in either of these eating disorders, and treatments for the disorders. Intimate partner violence, IPV, or domestic violence is any physical, sexual, and or psychological harm by a current or former intimate partner, someone you're having sex with, or a casual dating partner. IPV is a major health problem in the U.S. and it occurs across socioeconomic, religious, and ethnic backgrounds. For pregnant women, IPV is associated with an increase in low birth weight babies, prematurity of infants, and neonatal and maternal death. So it's a serious issue that we as nurses need to be assessing for when we encounter female clients. Physical violence includes certain things such as slapping, choking, or use of weapons. Sexual violence includes forcing one to engage in sexual activity against her will, or using sex, trading sex for food, money, or drugs. And then psychological and emotional violence is demeaning, humiliating the partner with words. As nurses, we have to screen all our clients for intimate partner violence. We need to document any signs of abuse and note that in certain states there are laws required mandatory reporting of domestic or intimate partner violence. So states such as California, Kentucky have laws that require healthcare providers, including us as nurses, to report intimate partner violence. There are certain questions that we should start asking our clients. First of all, asking them in the privacy, only with you and her in the room, regardless if her partner is male or female. Ask them to leave the room, and just ask, have you ever been hit by your partner? Does your partner ever make you feel bad about yourself? And do you feel safe in this current relationship? Are just a couple of questions that could be used to start the dialogue of assessment of intimate partner violence. If a woman does disclose that there is current or history of abuse, we need to work towards getting her, if there are children involved, into a safe environment. Thus, we need to know what resources and referrals are available in our area. Remember, we have to, and this is with all types of situations in which we take care of clients who may present in situations that are different than ours. What is our stance on violence? What are our beliefs or our biases about why a woman chooses to stay or feels that she has no other choice but to stay in an abusive relationship? And we have to keep in mind that there could be cultural barriers, socioeconomic barriers that prevent a woman from leaving a situation in which she knows it's not safe, especially if there's some financial or cultural ties to the relationship. So we have to make sure that we provide a trusting and safe environment for one to disclose and not feel judged if they are in an abusive relationship. Here on this slide is just a side-by-side view of the differences between sexual assault and rape, and so just become familiar with the differences between these two occurrences of sexual violence. So in summary of this module, we've talked a lot about women's health in general. We discussed in detail through video and voiceover the intricate details of the menstrual cycle, the purpose of the menstrual cycle. We've discussed irregularities, abnormalities related to the menstrual cycle, and other gynecological issues that affect women. We talked about women's health screening, looking at age-specific screenings and preventative measures, things like mammograms, self-breast exams, clinical breast exams, and Pap smears. We talked about changes in a woman's cycle leading up to menopause, where there's a cessation of the menstrual cycle for 12 months, and after that, a woman should have no more bleeding and she is no longer able to reproduce, and the uh, side effects or risks that come with the decrease in estrogen in a menopausal woman, things like osteoporosis, risk for heart disease, and ways that we can combat those things. Next, we talked about a couple of eating disorders, anorexia and bulimia, again stressing the differences between the two because there are some similarities, and treatment options for both. Lastly, we concluded with intimate partner violence, knowing that it is a common issue in the U.S. and that it has implications for maternal or women casualties, and how we as nurses can assess and assist women in leaving an unsafe and violent situation. Thank you.